Hi everyone, good afternoon. My name is Laurel Tangalakis and I'm the MIS Fellow at University of Washington. So early in my residency training, I was taught that it is critical during a paraesophageal hernia repair to achieve at least 3 centimeters of interabdominal length. And I was taught that the more length you're able to achieve, the better. However, I'm here today to tell you that that may not always be the case. Dr. Andrew Wright is a consultant for Medtronic. So as I just mentioned, the rule of thumb is typically to achieve at least 3 centimeters of interabdominal length during a paraesophageal hernia repair. As of today, our practice is to mobilize the esophagus and achieve as much length as technically feasible and safe during a paraesophageal hernia repair, with the same goal of at least 3 centimeters. We often work to achieve lengths greater than this, as we feel that the more length you're able to achieve, the less the recurrence rates will be due to decreased tension present at the esophagus. However, we've never looked back at our data to see if this holds true or if there's any value to achieving this extra length. So today's the day that we are going to look back at our data and see if our strategy of achieving as much esophageal length as possible holds any measurable value on recurrence rates. At our institution, we have a prospectively collected database of all patients that have undergone a first-time laparoscopic paraesophageal hernia repair. Starting in 2015, we began documenting esophageal length in our operative reports. Therefore, we decided to look back and do a retrospective review from 2015 to 2019 to see how esophageal length has impacted recurrence rates in this patient population. So we had 176 total patients. Out of that, 103 patients had a 6-month follow-up upper GI. It's our practice to obtain a routine 6-month follow-up upper GI postoperatively, regardless of symptoms. Based on this, we define radiologic recurrence as any hiatal hernia seen at least 2 centimeters above the diaphragm. Based on this, our recurrence rate was 24.3%, or 25 out of 103 patients. We then looked at the data broken down by esophageal length. As you can see here, the majority of patients had an esophageal length documented as 3 to 4.5 centimeters, or 86.4% of the time. Rarely, 3.8% of the time, the surgeon elected to accept less than 3 centimeters of interabdominal length without doing a cholecystroplasty. In fact, our rate of cholecystroplasty was quite low. It was only 3.8%. We elected to exclude patients who underwent a cholecystroplasty from the remainder of this analysis, as we felt as it was a confounding variable to looking at recurrence rates. So we have a bar graph here that represents recurrence rates and esophageal length. The horizontal axis shows esophageal length, and the vertical axis shows recurrence rates. The numbers above each bar represent the number of patients in each group. It is broken up by esophageal length, documented in half-centimeter increments, which is how it is documented in our operative reports. And as you can see here, we often mobilized beyond the accepted length of 3 centimeters, and we even achieved up to 5 centimeters in some patients. This graph demonstrates that our recurrence rate varied from 22% to 33%, but overall was similar and there were no statistical differences here. We were surprised by these initial results. We were expecting to see a difference in recurrence rates, especially as esophageal length increased, as this is what we've always believed and we've based our practice off of. So we decided to further our analysis and look at the extremes of short versus long esophageal length to see if we could see a difference here. We defined short esophageal length as less than 3 centimeters, and we defined long as 5 centimeters or greater. However, even when we did this, we still saw no significant difference. We proceeded to analyze the data in a variety of other ways, grouping esophageal length in different combinations, but despite all of this, we still did not see a difference. Since we still weren't convinced that this could possibly be true, we then decided to look at the data based on average esophageal length and compare it in the recurrence versus the no recurrence group. Based on that, we found our average esophageal length to be 3.8 centimeters. We then compared the average esophageal length in the two groups, and it was the same, 3.8 centimeters in each group, with no difference. This supported our previous finding that length does not impact recurrence rates. So after exhausting multiple ways to stratify and analyze the data, we still came to the same conclusion, that there was no correlation between esophageal length and recurrence rates. However, we thought there must be some confounding variables present that are not allowing us to see the difference that esophageal length was making. So we started by doing a univariate analysis. We looked at smoking, BMI, age, sex, operative time, and mesh use. Based on this univariate analysis, not surprisingly, we did see a correlation with BMI and recurrence rates. But we then did a multivariate analysis comparing BMI to esophageal length, and we did not see any correlation here, showing us that this wasn't a confounding variable to our results. So in conclusion, we looked back at our data to ask ourselves about the role of esophageal length in paraesophageal hernia repair. We saw that we were able to achieve greater than 3 centimeters of length in the majority of patients with extensive mediastinal mobilization. And in many patients, we were able to achieve even more length than this. These results surprised us, as we found that recurrence did not depend on esophageal length, and it did not appear that achieving additional esophageal length conferred any benefit. And it is true that in some patients, it may be difficult to achieve even 3 centimeters of length despite extensive mediastinal mobilization, as we saw based on our data. But it may be that the ability to achieve this additional esophageal length, and especially the recurrence rate, may depend on other patient factors as opposed to technical aspects. We tried to account for this through our univariate and multivariate analysis, looking at the different confounding variables, but we were limited due to the size and the extent of our study. So in conclusion, extensive esophageal mobilization is not always necessary, especially if it is technically difficult. And if all you can get is 3 centimeters, that may be just enough. Thank you.